All right. Good morning, guys. Ready for round two. If you aren't knocked out after our wonderful evening yesterday at Capitol Grill, I thought it was a great time. Thank you, everyone, for coming. And again, thanks to SI Bone for sponsoring that for us. Again, our sponsors, NuVasive, Carlsmed, SI Bone, and Medtronic, who made this possible. And today, obviously, we have a very special guest. The person who really made all this possible is David Herche. As you saw him on the video yesterday, but an exceptional gift that's going to provide great experience for trainees and fellows alike here for the next several years. So with that, I'm going to introduce Dr. Okonkwo once again. One of the things I left off of his biography yesterday on purpose is that in addition to just about every other possible position and accolade you can think of, he's also the team neurosurgeon for the Pittsburgh Steelers and has been in that capacity for a few years now, taking over for Joe Maroon, who was a longtime Steelers neurosurgeon prior to that. So we'll take it away, David.
Thank you.
Yep.
Appreciate it. All right. Yesterday we had fun talking about the relationship between venture capital, kickstarting great ideas, how that translates into innovation that leads to impact on patients and their lives and their outcomes. And then today we get to talk about something completely different, which is fun in a way, because I think I also want to give a talk that is entitled "So You Think You Want to Take Care of Athletes," and it's a different beast. But actually, what I've learned is that you really should make no distinction. Yeah, if you change, you actually create risk and harm, and so you just have to do the exact same thing that you would do for anybody. The difference is that sometimes we're facing timelines. Like I saw a former NFL player in clinic last week, and he's been out of the league for 8 years, but this guy was a legend, and he's got a 4-5 disc herniation, and it's Monday, and he's like, well, how am I going to be fixed by Sunday? And it's like, that's how it worked when you were playing, sir. Like, the goal was for you to be fine by Sunday. That's not how it works in real life. Like, we're going to have to reframe the timeline here. We're going to get you better, but it's not going to be by 1 p.m. on Sunday. So we're going to run through some things about what this looks like in athletes. These are my disclosures. They haven't changed. All right. There are 12,000 new cases of spinal cord injury each year in the US. The demographics and perspective of spinal cord injury have actually changed radically, which is that this used to be a disease of young males doing things they probably shouldn't be doing. And now the most common form of spinal cord injury in the United States in 2024? It's a central cord syndrome in someone over the age of 70 with underlying arthritis who falls and then gets a hyperextension injury. So that's now the most common form of spinal cord injury in the US. But it still remains that 9% of spinal cord injuries come from sports-related events, and football is the most common source of a spinal cord injury. Although what's also fascinating is the risk of spinal cord injury diminishes the further you get into the sport. So it's more likely to happen in a high school player than a college player than a professional player. And then the other real significant injury that we see, which is fortunately dramatically more common, would be something that happens to the brachial plexus. And we know that there are the injuries that happen at Erb's point. There's approximately one stinger per game in the National Football League. And then we do 1.7 concussion evaluations each game in the National Football League. So there's almost 3 players a game that get evaluated. And now there's this entire structure built around this in the NFL, right? Like the safest place in America is on an NFL football field on a Sunday afternoon. Like the medical staff that surrounds that is insane. There's 25 There's 25 hand-picked physicians across all the specialties. We have an ambulance sitting right there. We can achieve anything. We can run any code. We can achieve almost any intervention outside of surgery right there on the sideline. But one of the most important things is just to get the diagnosis right. And so, herbs palsies are common, but the stingers are the most common. And then we know that there is this relationship between cervical stenosis, often congenital cervical stenosis, and the risk of a stinger. We look at Torg's ratio, which is the ratio of the sagittal diameter of the canal divided by the sagittal diameter of the vertebral body, so A divided by B. Torg actually just passed away, but Torg was an orthopedic surgeon in Philadelphia who, from the 1970s and the 1980s, really basically defined all of these things for us that still, in every one of Torg's observations in the 70s hold true today. Anyway, these are very common. And like I said, there's basically it's one stinger per game. In the NFL, the person can have a sensory disturbance, but can't have a motor disturbance in order to go back to play. So any weakness has to resolve before they can go back to play. If they're numb, we're not so worried about that. But the weakness creates risk for further injury. So they can't play if they're weak. And then you have to remember a couple of things about stingers. They're unilateral. And I'll talk a bit later about a case of where someone presented with bilateral stingers, which you have to recognize immediately. There is no such thing as bilateral stingers. If it's bilateral, the problem is in the spinal cord. And then there should be painless motion of the spine. And if there is pain involved in the spine itself, then you have to be worried about something more than a stinger. But that's a consistent part of what happens on Sunday afternoons. So we'll run through some cases here. So this is a 23-year-old linebacker who presents to the NFL Combine, and each year we're charged with reviewing the medical records of about 175 people. It's not the best 32 players, because as a franchise, the front office is focused on who's our 5th round, who's our 6th round draft choice. You're not going to get the 32nd best player in the 6th round. So they have this draft board. So it spans the entire spectrum, including, who are the targets for the 5th and the 6th round draft choice, just as much as the 1st round draft choice. The metric of success in the NFL is if you draft somebody, they make the roster, and they get to a second contract. And that ends up being a big part of the medical evaluation is, do they have an underlying medical or orthopedic condition that means that their life expectancy as a professional football player is shorter. And you want to use draft capital on people that are going to contribute to your team, but also be good enough to stick around for a second contract. So this guy has had multiple stingers in college. They were always unilateral. They were more frequently on the left. He never lost time. He denies any and all symptoms. So is this guy a risk? Are you going to risk a draft pick on someone with this history? And so out of that 175, there's about 15% or 20% of them that have a spine or a concussion history that means that I have to pay extra attention. We're allowed to bring a certain number of players to Pittsburgh, and then they'll get a secondary medical evaluation when they come for in-person visits. But the way the combine works is insane. So there's 4 rooms. We work with the same 7 franchises each time. So each room has 8 franchises. One person from the medical staff is assigned to every single player. So rather than they're going through 32 medical evaluations, they just go through 4. And then as they come through, we know, because we have our list, whether our team is interested in them. And then if there is a medical or orthopedic or neurosurgical issue, then while they're being presented, we can then step up and do an exam and ask more questions. And then if we want anything, MRI, CT, X-ray, there are 8 trucks sitting out back, and then they just go and get an MRI. They're like, I want a left knee MRI. Okay. The guy walks out of the room and goes and gets a left knee MRI. That's the way it works. And And it's actually pretty darn wild. So we get X-rays. X-rays look pretty reasonable. He's got some neuroforaminal stenosis at one level, no central stenosis, spinal cord's fine, there's no disc herniation. So what do you think? Is this guy good to go?
Yeah.
Yeah, he's good to go. But we all will recognize that his history of stingers portends future stingers. But he's never missed time with any of his stingers. He has a normal exam and a pretty benign image, because this is actually a pretty benign MRI. It's like these guys are 22-year-old elite athletes with spines that look like they're 65 or 70 years old. It's insane. And I mean, the wear and tear is early and pretty substantial. But we will recognize that this guy has a risk of future stingers. He's never missed time in the past. So we know he's probably going to have more stingers, but he's probably going to be fine. This is a running back who had a left-sided stinger his freshman year that caused him to miss practice, and then he had an additional left-sided stinger his senior year, and then he didn't play again. It was at the end of the senior year, didn't play again. And on exam, he's got deltoid atrophy and he's got weakness in his supraspinatus. So then you dig deeper and you realize he's got 10 stingers going all the way back to middle school. He had his first stinger in middle school. And but we go through the same process. So x-rays actually look pretty good. MRI, you're starting to see there's a little bit more degenerative disc disease, but now he's got severe neuroforaminal stenosis. He's got severe neuroforaminal stenosis, disco-osteophytic disease at C4-5, and deltoid weakness and supraspinatus weakness. So what's the answer for that guy?
Get an EMG.
Yeah, so that guy is not getting cleared to play. This guy is not eligible to be drafted. He needs an EMG. You need to have clarity about whether there's ongoing denervation or whether it's just reinnervation. But this guy has multiple steps ahead of him. And then it gets into this really tricky situation because his deltoid weakness and his supraspinatus weakness are not going to have any effect on the rest of his life, but they make him ineligible to play football. So are you going to have a C4-5 ACDF that you would otherwise never do this for someone with slight weakness? That person would be treated with physical therapy, and then they don't, when you're an accountant, you don't go to work and wonder if you're going to have another stinger that day. Right. But do you have an operation in the setting of a physical exam and a set of imaging findings that we would never operate on otherwise? And that's a dilemma. And it may not resolve because you have to tell these guys, like I saw right before the Tokyo Olympics, I saw a wrestler and his goal was to win a gold medal, and he had a 5-1 disc herniation, and he had weakness in EHL, and that was it. And he was telling me, he's like, I cannot win a gold medal if I can't create the correct pressure in my great toe. I can't win a gold medal. And he's like, but he has like 4++ out of 5 strength in his EHL, but he could tell the difference in the strength in his ability to launch off of his right foot. So he's like, how do you fix it? I'm like, dude, I can't, there's no operation that takes you from 96% to 100%. I can't fix you. I certainly can't fix you in time for the Olympics. And he didn't win a gold medal, and he knew it. And he's like, I have to figure out how to wrestle in a way that hides the weakness in my right EHL, but it was weakness that the rest of us wouldn't even perceive. But the elite athlete knows the difference, that tiny little difference, and it's the difference between a gold medalist and a non-medalist.
How hard is that conversation? That's got to be a difficult conversation to tell that guy no, right?
Yeah.
Not really.
No. Well, I mean, this was a combine evaluation, so Oh yeah, I didn't operate on him. Yeah. 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 All right, now let's get more complicated. So, 20-year-old college football player with intermittent neck pain, and just kept complaining about his neck, so he gets X-rays, and the X-ray then leads to more testing, and he's got Klippel-Feil syndrome, hypoplastic C1 posterior arch, C1 lateral mass anomaly, congenital fusion at C2-3. So do you let this guy play football? Kyphotic, yeah. This guy almost single-handedly won the national championship for his college football team, and he's a projected first-round draft pick. Projected career earnings of $60 million. No, he's got intermittent neck pain. Damn normal. All right, so that's not actually what happened to this guy. What actually happened to this guy was that in spring practice, in a routine play, in spring practice, he makes contact with someone on the defensive side of the ball, falls to the ground, he's quadriplegic. And he recovers full strength within minutes, actually walks off the field. And and so he had a spinal cord neuropraxic event, and that's what led to all of this imaging. But it's interesting. So if you have an incidental discovery of a Klippel-Feil, what do you do? But what do you do when the Klippel-Feil syndrome produces a spinal cord injury? And but he did walk off the field. He was tetraplegic for a very short period of time. So he has congenital spinal stenosis. He's got a 9-millimeter canal diameter. He's got a hypoplastic C1 posterior arch. He's got a C1 lateral mass anomaly with an abnormal occiput to C1 joint. And then at C3, he's got a C2-3 congenital fusion as part of his Klippel-Feil, and at C3-4, he's got a disc herniation and spinal cord compression. But now he's neurologically normal. So is he allowed to play football? And again, what if he's a projected first-round draft pick? Does that change your?
It went through this variation, but this is spondylosis or kyphosis, right? You could conceivably fix that fusion.
That's what I was gonna say, 2-3 AC, yeah.
3 AC.
Or 3-4 AC.
Well, it's like the other guy. Yeah, you got a little deltoid weakness. Well, we'll do your ACDF at C4-5 and make it a permanent C5 palsy. I mean,
we're gonna reach clarity here by making this permanent and more profound.
We're gonna take you out of the gray area.
So
I think this guy's problem is that spot.
Yeah, it's
Yeah.
a Klippel-Feil that caused the degenerative pains.
all right. My approach in these, and when you play for a Power 5 program that's trying to win national championships, it's incredible, the structure that gets put around these guys. So they send a private plane down to pick his mom up, fly over, pick him up, fly him up to Pittsburgh in a private plane for a clinic visit. That's how they roll. And so comes to clinic, and he's with his mom, and his mom served in the United States military for 20 years. She's not a pushover at all. And the conversation is, listen, we first care about you and your son as a person. Like, our decision making here is first and foremost predicated on what is the correct answer for you as a human being. And if we make a choice about what's best for you as a human being, and then there's a path towards returning to football, we will have that conversation later. but the first focus is what is the right answer for you as a human being. So as someone with significant spinal cord compression at C3-4 who has already proven, and I don't show that didn't show the video, but it was the most innocuous contact you can imagine that produced tetraplegia. So this is someone that, in my perspective, can slip and fall on ice on the way out to get the mail in February and have the exact same thing. So to me, the correct answer for this person as a human being is a C3-4 ACDF. And then we can make choices about that C3-4 ACDF to try to connect them to whether you, let's not make choices that will then say football is a no. If we have choices on the table that preserve the opportunity to play football and they're equivalent, we're not going to make an inferior choice to try to get you to play football. We're going to make, if we have equivalent choices, let's make the choice that it carries with it the greatest likelihood of returning to football. So what surgery would you do? What would you do, Bill?
That's what I was.
So you'd use a synthetic interbody plus I factor, or? Yep. Yeah. So I will say that is my most common choice in the elite athlete. But I chose not to do that in this case because I knew where this was headed, which is he already has a congenital fusion at C2-3. Now we're going to add a surgical fusion, and we're going to be in a situation where we are going to have to make a decision. You know, a 2-level cervical fusion is considered a contraindication, or at least a relative contraindication to return to a contact sport. Now, I don't know where that dogma comes from. And actually, if you look for that evidence, there is no evidence about that.
Yep.
Exactly. Well, I'm glad. So we by the time this was all said and done, there were 6 opinions and 2 lawyers, right? And yeah, yeah. In this situation, the agent was on the periphery, but like over the last few years, you know, agents for college players, that's now just how it rolls. So I chose to use allograft because I wanted to be able to confirm arthrodesis as part of this, where I knew this conversation was going, to say it's a God-given fusion and a surgical fusion, and these aren't the same thing, and we shouldn't view this through the same lens as a 2-level fusion. And then I get burned because 12 months later, there's not graft incorporation of the inferior aspect. And so, you know, the upper part of the graft is incorporated, but the lower part hasn't.
Sucks or not.
Yeah. So do you let this guy play college football? He misses 1 season. If he misses another season, that's pretty much going to be it for him.
No lucency.
He has 0 symptoms. There's no lucency around the screws. We fixed his stenosis. So what I've started to do in these guys is I've started to apply kinematic testing, and we have these bioengineers that work with us, and they do these amazing things where they take these motion videos with fluoroscopes and they run them through this analytics pipeline. And so I can prove with kinematics that pre-surgery he had motion at C3-4, and then at 6 and 12 months after surgery, C3-4 there's no motion. He's fused. He has a stable pseudoarthrosis, right? That there's the graft is not incorporated, but there's no haloing around the screws. There's absolutely no motion at C3-4. And at every other level, there has been no change in the motion of any other level of his neck in relation to now having 2 levels fused. So we haven't changed the kinematics of the rest of his spine by doing an ACDF and we look at it in all angles. So we have created no motion at C3-4, and we have created no change in motion at any other segment. And So I said, sure, go play. He still doesn't have a perfect diameter of his cord. This was one of the things that got brought up yesterday. So now at 2 years or 21 months after surgery, the inferior aspect catches up. He's played a year of college football. He is now got after that year of college football, he now has graft incorporation inferiorly. So he has a God-given fusion and a surgical fusion. His spinal cord no longer has T2 signal change. There's CSF signal around the cord. It's 10 millimeters, so it's right there on the cutoff but it's 10 millimeters at a level that's fused. It's not 10 millimeters at a motion segment. It's 10 millimeters at a level that's fused. So would you draft him? You don't know why not? He's got clipple file. He's got a hypoplastic C1 posterior arch. He's not, but so would he get a second contract? So this guy's no longer a first round draft pick, right? That's yeah. So you draft him, but not in the first round. Look, you have to have a normal neurologic exam. You have to have resolution of the T2 signal change. You need to have restoration of the canal diameter. You need at least a stable pseudo-arthrosis or arthrodesis. And then it's shared decision making where, the athlete has an opinion, the family has an opinion, but they're over 18. So they can override their family. You bring many voices into the room. And we brought in 6 spine surgeon voices. There was not consensus. There was not unanimity amongst those voices. And then ultimately it was the athlete's choice. So I am exposed. I have limits on my malpractice my malpractice policy has a limit. And so I have a personal umbrella policy that carries me, past that. We've created legal structures in our life that would shield personal assets that relate to, my family's financial security. You think you want to take care of athletes. But there's real risk. And we were talking about this in the car from the airport, that this malpractice verdict against the Rothman Institute for the Philadelphia Eagles special teamer in February of 2023, $40 million contract, the $40 million verdict for a 31-year-old special teamer. And that's crazy. And then the way it works, like Rothman has a maximum, and because they're a private group, every partner at Rothman has to stroke a check to cover the delta between their maximum malpractice coverage and the actual verdict. Every partner in Rothman had to stroke a check. Yeah, it's different. Anyway, he's in the NFL. And I can tell you that when he went back, every Saturday I DVR'd the games, and I couldn't rest. There was every Saturday that he played when he went back, when he was on the field, I was either watching or they played Pitt. And I went to, and the team invited me to the game, and they're like, "Do you want to come on the sideline?" I'm like, "I don't want to be on the sideline."
So David, this conversation.
I went out to dinner the night before with the coaching staff, and I'm like,
So go back to that discussion. You have all those people in the got 2 lawyers, got 6 neurosurgeons, got the patient in his family.
we had 6 spine
Or
surgeons.
spine surgeons, sorry.
Yeah.
But so when you're having that conversation in this gray area, it's the same thing I said. Why not? Has to file and a 10 millimeter down. So how are you counseling? What's your conversation like with that player? Right? Because ultimately it's his choice, right? And then
What do you tell the team?
What I told the player, that based off of everything, including the kinematic testing, what I told the player is every day that you walk on to a football field, there's risk. Okay. Do I think that we have done everything that we can do to lower your risk of catastrophic injury? I believe that we have done everything in our power to lower your risk of catastrophic injury. Have I eliminated your risk of catastrophic injury? No. Do I think that your risk of catastrophic injury is higher than the guy lining up next to you? Yes. Do I know what the delta is between your risk and that guy's risk? No, I don't. But, you know, he's good.
Yeah, he's got a lot. He's got a
Two-level fusion, kyphotic deformity, residual 10 millimeter canal diameter. And I'm not going to be the guy that takes responsibility for this. They don't say that out loud, but that's the reality.
Yeah.
The no is radically easier than the
Right.
yes.
Yeah, and that's what you said before, right? I mean, it's easier for the surgeon to sit there and take all the $60 million contract and his kids' desires to play out of the window, kick that out the window and not accept the risk of saying no player didn't play.
Yep.
Kind of the dynamics of this are really intense. I mean, because you're dealing, I mean, this is so out of the box from typical neurosurgery training, teaching. I mean, these are begging questions that we've never really seen before, and you're discussing for the first time. And when you look at all of the things that are at play here, and I'll tell you, you don't have to be an NFL coach, but just as or NFL doctor, but just as a neurosurgeon in our communities, we see a lot of high school athletes, right, coming into your office with some football-related injuries, and you see some bad problems, and you see parents bringing these players into the office. They're in an irrational state because they have their son or child who's got this potential for college and everything else. These people don't want to believe or hear the things that you're telling them. I don't know if you guys have had that experience.
Yeah.
But you can't, it's hard to have a rational conversation with some of these families.
Yeah.
So in this case, you say, here's the facts. Parents, you got to make the decision.
Well, when they're 18, no. When they're 18, you're, I mean, legally, you speak to the person.
Right.
And you engage the family. But if the player doesn't want the family involved in the conversation, then the family's not involved. But that's a red flag to me, right? The previous player we were talking about, I mean, he and his mom are super tight, and that was obvious. That's a red flag to me if someone is trying to hide voices from the conversation. But by law, he's an adult. Yeah.
What do you think of this $40 million lawsuit? I'm not aware of that case versus your situation here where you have a successful operation.
Well, a successful opera. I don't know if it's a success yet, man. I mean, talk to me when he retires. Every time that team plays,
do you feel
my pulse goes down and stress, my blood pressure goes down and stress, but then this.
Then, I mean,
What is my equity stake in your career? Yeah.
Do you get a Rolex for Christmas?
No. Sarah. Yeah.
I think
For sure.
a hockey player with a higher velocity injury into a wall. Would you do the same thing?
Yeah, so that's a great question, and we are wrapping up and polishing. We went through this enormous Delphi process looking at this list of scenarios where you don't have evidence to guide, but these are things like, the incidental Chiari malformation with or without syrinx. Okay. And then what we did was we created this box of low impact, low frequency, all the way through high impact, high frequency sports. And we divvied up the sports into those quadrants. And then we went through this Delphi process to say, yes, for this scenario, a low impact sport makes perfect sense, but a high frequency, high impact sport doesn't, for example. So yes, the sport matters for sure. Yeah. Okay. So 21-year-old college football player, again, for an elite Power 5 conference that's trying to win national championships, comes out of a game with a stinger, but the trainer realizes that it was bilateral, pulls in the orthopedic surgeon on the sideline, confirms it's bilateral, and then these guys know, like, that's a problem. This is not a stinger. It's bilateral. So they pull him from the game. It was gone. Like everything was, he was neurologically normal, but it's bilateral. So they appropriately recognized that, took him out of the game, and then got him x-rays and an MRI, and he's got a C3-4 disc herniation with T2 signal change inside of his spinal cord. What's fascinating about football is that C3-4 is disproportionately affected. C3-4 is much less common in our elective practices. You're much more likely to see C5-6, C4-5, C6-7. You're much less likely to see C3-4, but C3-4 happens at the same frequency as the other levels in the football player. So the athlete and the agent ask about arthroplasty. So will you do an artificial disc? And this guy, this guy likewise has professional aspirations, and he's freaking good.
This is all sensory.
Correct. Yeah. So.
Let me ask you this: has anyone ever done had an arthroplasty and gone back to the NFL?
No, but there are 3 hockey players in the NHL. There's an MLB player. There's an Aussie rules football player. This has been done in many professional athletes, 0 football players, 0 professional football players. It's actually been done in 1 college football player, but there's no follow-up. And the player wasn't named. There was a case report about an arthroplasty in a college football player, but there's no follow-up, and I have no idea. None of us have any idea what happened to that guy. The hockey players actually did well professionally. Jack Eichel was fascinating because he commanded a trade to a franchise that would let him get an arthroplasty because his original franchise said, no, you need to get a fusion. We don't believe that an arthroplasty is appropriate. And he and his agent commanded a trade, and the Vegas Golden Knights would allow him to play with an arthroplasty. So he was traded to the Golden Knights, got an arthroplasty, and has continued his NHL career. Pretty fascinating. There is one UFC fighter, but these are tricky things. And one of Zach's former fellow residents published this amazing case report. This person had a multi-level arthroplasty, and then she fell down and then had implant failure from a fall. Not from 22 miles an hour in both directions, 6'4", 250 hitting each other. So there are contact sport athletes that have had arthroplasties, but no one in the NFL. There's risk, so they were comfortable not doing it. And it's the weird thing. So in the football players, I'm still more likely to use allograft if I think they're going to the NFL, because I know what my colleagues do at the combine. They shut people down and then they downgrade people. So if someone has a future in the NFL, I'm still more likely to use allograft. But if you're in any other sport, or if you're just trying to get back to college football, but you're not going to play in the NFL, I use 3D printed porous titanium and I-Factor. Yeah. Anyway, turns out that if you have one of these things, you're much less likely to get a second contract. Your career is shortened if you're drafted with a history of a cervical spine injury. But this guy was drafted in the 2024 draft and is excited about his professional future.
You do the allograft just so you can prove that it's.
Yeah, because I know what happens at the combine. All right, so this is the last one. So 21-year-old college football All-American, expected to be a first-round draft pick. Knew as a child that he had idiopathic scoliosis. Gets an X-ray at the combine that documents his idiopathic scoliosis. Would you draft that guy into the NFL? Never had an issue. What if he's 15 years old, about to start high school? I mean, yeah, I mean, we don't really have, but that's Ryan Shazier's X-ray. And this is the Monday Night Football play where Ryan is a T9 Asia A paraplegic as a result of this play. So he rolls over and, can't, puts his hand right there at the apex of his scoliosis, knows where his problem is. Like there were people who were asking me why didn't we put him in a cervical collar and all this other, why didn't we board him the way you're taught to board? It's like, well, because we did a neurologic exam and he didn't have a freaking cervical injury. So why would I torture a human being with unnecessary interventions when it's obvious that this is a thoracic problem? So can't move his legs, he's paralyzed, no sensation, no motor, and he puts his hand exactly where the injury was. So that's here in Cincinnati. I was at that game back in those days when it was Joe Maroon he was a neurosurgeon for the Steelers for 38 years. And once a year he would have some conflict and he would ask me to fill in for him for an away game. And so this was the one away game I went to that year.
We were not on the voice.
And so we come to University of Cincinnati Medical Center, and he recovers his bulbocavernosus reflex, which means that he had resolution of spinal shock, and he is still a complete Asia A spinal cord injury, no motor and no sensory function below T9. So we drill every summer, and now we have to do it twice. Since DeMar Hamlin, we now do it twice. We drill twice before the season collectively, where we run through all these scenarios. If someone has a seizure, if someone goes into cardiac arrest, if someone has airway compromise, if someone has concern for a neurologic injury or a cervical spine injury, we drill all these scenarios. Everybody understands, like even we know exactly who's standing where when you're gonna load them onto the board. Like we drill this, so we all know exactly. Like that's our head team physician always is at the foot. The head athletic trainer is always on the right side of the patient at the head. Like, so we drill this. Everybody knows when you go out, you know exactly what you're gonna do. It's the safest place in America. Because everybody knows exactly what they're supposed to do. So what are we gonna do? And this is tricky. Turns out this is an injury that's never been seen in football before. And if you understand scoliosis, then you understand idiopathic scoliosis. At the concavity, along the apex of the curve at the concavity, you have hypoplastic pedicles on the concavity. And he fractured the pedicle at the concavity. So we get to Cincinnati. I'm dressed like this. Everybody's looking at me like, who is this dude? The neurosurgery resident is like talking to Joe Chang and saying, I don't know who this guy is, but he, keeps talking to me. And then Joe Chang was on call, and Joe comes in, I was telling this story the other day, and then Joe, yeah, there's 25 people in the trauma bay waiting for us. And I'm in the ambulance with him. You know, we get there, and then Joe was 10 minutes behind us. So we had already finished the primary and secondary survey, and he's about to go back to the CT scanner. But Joe walks in, gets the debrief from the head trauma surgeon, and he puts his arm around me and looks at everybody and says, "None of you know who this guy is, but if we just do exactly what he tells us to do, it's going to go much better for all of us." Which was like, that made my life so much easier because I stayed at his bedside for 48 hours here in Cincinnati. I don't have privileges. I don't have an Ohio medical license. Like, these people are under no obligation to include me in the management of this, but it's what I freaking have devoted my entire life to. It's not just not the athlete, but the spinal cord injury patient. So he gets a CT scan, he gets an MRI, and there's a spinal cord contusion, but there's not actually neuroelement compression. So we choose not to operate in that moment. And then we could take him up to the ICU. He actually gets better. So as Monday night turns into Tuesday morning, he starts to wiggle his great toe. And then he starts to get visible contractions of his quadriceps on one side. And so it's like, wow, okay. And I'll go through some of the other things that we were doing in the interim. But on the morning of post-trauma day 2, he loses all function. Again, so he's back to totally paralyzed. And at that point, we had already arranged things. I didn't know that Cincinnati is in range of the helicopter for Pittsburgh, because I thought we were going to have to do fixed wing transport. But it turns out, like, a helicopter is much easier. You just fly to the top of the helicopter, you go up an elevator, you fly to the top of the next hospital, and you go down the elevator. It's way easier than, I didn't know that the helicopter is fixed wing. There was one trainer, one PR guy who stayed behind with me, and one ops guy who stayed behind. That was so amazing. He like handed me a toothbrush and a fresh pair of underwear the next day. I was like, I appreciate that.
Did you also have a fresh pair of underwear the same night that your injury happened?
Anyway, so we had it all set up for this helicopter ride, and then there was a guy who like sent a plane. So someone sent a plane. I get on the private plane. Ryan gets in the helicopter. The trainer goes with him in the helicopter. Turns out our trainer's afraid of heights, and it's a glass bottom helicopter. So he's basically having a panic attack for the entire flight from Cincinnati back to Pittsburgh. But he right before we were going to get on the helicopter, I realized that his exam had changed and he was paralyzed again. So we land in the helicopter, go straight to the MRI, and he had interval development of an epidural hematoma with spinal cord compression. So then we went straight to the operating room, and I did a short so I drilled down the pedicle, got rid of the epidural hematoma, decompressed the spinal cord, and did a short segment fusion. You know, I'll roll through this in the interest of time, but steroids are very controversial. But let me say this: a 25-year-old elite athlete who is the most incredible physical specimen you're ever going to see is not going to suffer the pulmonary complications of being administered high-dose steroids. Okay, so we slogged him with high-dose steroids. We gave him chilled saline. Like in Pittsburgh, we have chilled saline in the training room. So if we have a spinal cord injury in Pittsburgh, you get chilled saline before you even get in the ambulance. That wasn't the case in Cincinnati. But we gave him chilled saline in the emergency room, and then we put an Arctic Sun on him. That's the hypothermia strategy that is used in that hospital. I like the intravascular cooling catheter, but we only had the Arctic Sun, so we did surface cooling. This was 2017, so we hadn't got to the point of using lumbar drains and spinal cord perfusion management. So he only got mean arterial pressure blood pressure management, and then we threw the kitchen sink. So we put him on high dose omega-3 fatty acids, and we gave him hyperbaric oxygen. He did 29 dives. That is complex. There is very serious complexities associated with taking a critically ill person down to a hyperbaric oxygen chamber, but we pulled it off. They're called dives when you go into a hyperbaric oxygen chamber. So he had 29 dives in the hyperbaric oxygen chamber. And then the biggest difference in his life was, it was made very clear to me that resources, there were no resource obstacles, that I had carte blanche to do whatever I thought was right. And so rather than getting 20 physical therapy sessions, he got hundreds. Rather than being in the spinal cord injury rehab unit for 14 days, he was there for 6 weeks. And he has a normal neurologic exam now. He's normal. And he recognizes with crystal clarity the difference between, what he was allowed to receive for care and what anybody else gets for care, which is why he has stood up his foundation. He has this Golden Windows program. And so he doles out grants every year now to spinal cord injury patients to fill the gap between what their insurance companies, you either get you get one wheelchair. It's either a push or it's electric. And the electric is radically more expensive. So everybody chooses the electric, but you can't go to dinner with your family with an electric wheelchair. It just doesn't work. So, that's one of the things that the foundation does is buy the second wheelchair for people, and it radically changes their independence and what they can and can't do in life. So he has crystal clarity about the difference between his experience as a spinal cord injury patient and what the typical experience is for a spinal cord injury patient. And we thank Mr. Herche for allowing this to come alive, and I appreciate your time, and it's an honor to be here. Thank you.